All right. Good morning, everyone. I think we're going to get started with our session today. I'd like to welcome you to this webinar on strengthening universal health coverage through behavior change approaches. Next slide, please, Nikem. I'm really pleased to welcome you all here. Today's event is hosted by the Health System Strengthening Accelerator Project. I'm Laurel Hatt. I'm the technical director of the accelerator, and I'm pleased to share this work that our colleagues at USAID's Office of Health Systems and our colleagues on the accelerator have been supporting. The accelerator is a program that provides coaching support and technical assistance to country institutions and organizations across a broad range of health system strengthening challenges. We are in the home stretch of this project. This is our 6th year, and we have just a couple months until we're closing down. So we've had a bunch of great webinars, and I'm really pleased that we're able to host this one as well today on social and behavioral change approaches and financial protection. Just a quick reminder. The accelerator program has been led by Results for Development, R4D, with core partners HSTF and ICF. And ICF will be sharing much of the presentation today, so really glad you could join us. Next slide, please. So today's session will be about exploring the application of social and behavioral change approaches to improve health systems. This has been an important part of the accelerator's work, so we're very excited to be able to share some of that, some of the learnings that have emerged from that. We're going to go through, this is the agenda for today. We'll first start with a bit of framing, just providing some framing on how financial protection efforts can help, how including behavior change in financial protection efforts can help address social and behavioral drivers that impact the effectiveness of implementation. We'll hear a presentation from my colleague Molly Loria about a spotlight brief that she and colleagues worked on, looking at some of those levers that could affect the implementation of financial protection programs. And we'll hear two other presentations from colleagues also looking at the application of social and behavioral change approaches. At the end, we're hoping to leave a bit of time for Q&A that will allow those of you who are joining from the audience to type in your responses, to type in your questions, and we'll hopefully have a bit of time to engage our panelists in some reflections on the topics. Next slide, please. So the overall objectives for today: first, we will provide an overview of how social and behavioral change, or SBC, can improve health systems and accelerate progress towards UHC. Then we'll hear from Molly on recommendations for integrating SBC to enhance financial protection programs. And lastly, we'll hear insights on how to apply behavioral approaches into the design, implementation, and research on health and health systems programs. Next, please. Just a little bit of housekeeping. I'm sure everyone has done a million of these Zoom webinars by now, but if you would like to pose a question to the panelists, you can find a box at the bottom of the screen, and you can type in your questions there. They'll be seen by the panelists, and then either we'll try to answer in real time, or if we're not able to type and multitask while speaking, then we'll come back to some of those at the end of the session. So please do, as we're going along, feel free to post any questions that you may have. So today we have 4 great speakers along with me as the moderator. I'm really pleased to have Kama Garrison from USAID's Office of Health Systems, Molly Loria from ICF on the Accelerator Program, Matt Barnard, who's also from ICF at the Center for Behavior Change in London, and Jana Smith from Ideas 42. And I'll introduce a little bit more about each of them as we go along in the presentation. Next, please. So I'm going to first provide some initial framing for this session, including some definitions of key terms and concepts for UHC and financial protection. Next. So financial protection, as I'm sure you all know, is really at the core of universal health coverage, along with equitable population coverage and quality service delivery. Financial protection is one of the dimensions in this famous UHC cube, where we're trying to reduce cost sharing and fees. The definition of financial protection is when direct payments made to obtain health services do not expose people to financial hardship and do not threaten living standards. And the key to protecting people is to ensure as much as possible that health services are being prepaid, that financing for health services is collected in advance and pooled rather than relying on people to pay for health services out of pocket at the time that they're seeking care. And catastrophic out-of-pocket health spending, which is defined as households spending more than 10% of their budget, is still rising. And despite lots of progress in many contexts with social protection programs, more than 1 billion people, about 14% of the global population, still experience such large out-of-pocket payments each year. Even small expenditures in absolute terms can be really devastating for low-income families. And it's estimated that approximately 1.3 billion individuals are pushed into poverty or pushed further into poverty by such payments, including many people who are already living in extreme poverty. And there's many policy approaches to improve financial protection. There are payments made by government budgets to provide access to free healthcare or subsidized healthcare, social health insurance programs, community-based health insurance, and also social protection programs like voucher programs or cash transfer programs. Many different policy levers that can be used to provide financial protection. Next. So why are we talking about social behavior change in the context of financial protection programs? I think there's a little bit of a tendency, we've observed this, that financing programs are sort of technocratic, that they tend to overly assume that economic incentives are enough to expand access to care and provide financial protection. And they may overlook social and behavioral factors in their design, implementation, and assessment. A review that was done in 2021 found mixed implementation results for many financial protection programs, including challenges with going to scale and missed opportunities to consider contextual factors and non-financial barriers. Things like awareness of benefits that people are entitled to, lack of trust in the system, people being uncertain whether services will be covered and what quality those services will be, cultural barriers related to gender, ethnicity, or religion, and even just convenience factors are really powerful in terms of whether people make use of the benefits that they are entitled to. If it's much more it may be much more convenient to seek very basic care locally rather than take advantage of a free program that requires a 2-hour drive, that kind of thing. And so financial protection policies will have reduced effectiveness without careful attention to these kinds of factors. Applying SBC methods can improve equity as well in financial protection programs by focusing on these issues of access, trust, and acceptability, especially for vulnerable or socially and economically disadvantaged groups. So today's panelists are going to delve into a little bit of how USAID and the Accelerator have been considering these challenges and share some examples of how social and behavior change thinking has been applied to financial protection and health systems programs. Without further ado, then, next slide. I would like to introduce Kama Garrison as our first speaker. Kama is a public health professional with over 25 years of experience in public health programming, and she's currently a senior social and behavior change advisor in USAID's Office of Health Systems. Kama is going to provide some framing around the role that SBC plays in health system strengthening. Over to you, Kama. Thank you.
Thanks, Laurel. Next slide. So I think Laurel really framed some of this new thinking around using social and behavior change approaches in financial protection programming. So what is SBC? Just so that we're all on the same page, it's a systematic evidence-driven approach to improve and sustain changes in behaviors and norms and the enabling environment. We're looking at the key behaviors and social norms by addressing their individual social and structural determinants, or those factors that impact a person's ability to do something. And SBC is grounded in many disciplines. Here's only a few of the most prominent disciplines: systems thinking, strategic communication, marketing, psychology, anthropology, and behavioral economics. I think we often think of behavior change programming as communication only, but there are many disciplines that play into behavior change programming. Next slide. So for health system strengthening, there's many reasons that SBC is important. Just a few we list here. We all know that for many years, we've been looking at it for reducing risky behaviors and promoting healthy behaviors. But I think only, and to address gender and social norms, but only recently have we really paid attention to it for some of the things that affect the whole health system, like the provider's quality of care that they're providing, an individual's ability to use and adhere to products that are given to them, and the many different actors within a system that are required to do certain things to make the health system function. Next slide. We talk a lot about the bidirectional influence of SBC, so how behavior change improves the health system, but also how a functioning health system improves individuals' ability to do work, or even change social norms around certain practices. So here's just an example that we're actually looking at right now, that individuals aren't accessing malaria treatment, and I think we would often approach that by, oh, we'll start promoting malaria treatment to people. But actually, when we start to dig further down, we find out that the community health worker isn't actually providing it, and they're not providing it because they're not able to access it from the health facility. And when we unpack that, we realize there's certain economic incentives that the health facility has that makes them unwilling to give the malaria treatment to the community health worker to provide to individuals in the community. So how we are now looking at this problem is through, what can we do to incentivize a health facility that doesn't want to lose the funding that they get when they provide the malaria treatment, so that it's provided equitably to all people that need it. Next slide. So I won't spend much more time on this. I think I already emphasized that it impacts both the performance of the health system and the health of communities. And SBC addresses this and supports the behaviors of all people in communities and organizations. And we can think about even the norms within a health system, or the norms within providers, or the norms within government officials. And all of those are essential to making the health system work. So how we bring these two practices of SBC and health system strengthening together is really important. Next slide. We're right at the end. And I think I'll just go to the very last slide. So when we are talking about bringing these two disciplines together, we want to incorporate SBC approaches into our health system strengthening programming to influence the behaviors of health system actors who are essential to the provision and uptake of quality services. We want to utilize SBC approaches to increase chances for social change, which go beyond the accumulation of changes at the individual level to transform social norms and structures that influence individual decision-making. And then lastly, think about incorporating behavioral metrics into health systems programming. So for example, in financial protection that we're talking about today, are we measuring people's ability to access care, people's care-seeking practices? Are those reflective of the financial protection program that's been put in place? And that's all I have. The last slide is just some links, and we will move on to our next presenter. Thank you very much.
Great, thank you so much, Kama, for that additional framing on SBC approaches and health systems in general. I'm pleased now to introduce Molly Lauria. She is a senior research specialist at ICF with applied expertise in health systems initiatives and implementation research. And she is also a doctoral candidate at GW in health policy and systems research. So Molly is going to share the centerpiece of our session today, which is key learnings from a health system strengthening practice spotlight brief on financial protection and SBC. This is part of a larger series of health systems spotlight briefs, which are aligned with and amplifying the Office of Health Systems learning agenda. Over to you, Molly.
Thank you, Laurel. So as Laurel noted, I'm going to present some key findings from our practice spotlight brief, which you can see to the right. The brief explores how to integrate behavioral approaches into financial protection programs, and supported by 4 case studies along with implementation recommendations. So this brief is part of a larger portfolio of accelerator work that's led by Susan Petrick that focuses on enhancing equity in health systems through behavioral approaches. We'll share some resources that we've developed through this work at the end of my presentation along with today's focal brief. So through this body of work, we have found that there is great potential to integrate SBC into health systems work, including financial protection programs. And some of our key learnings through this work have been that health systems are full of human beings, from communities to policymakers whose behaviors or practices can be the focus of SBC interventions. Possibly, though, their behaviors cannot change due to the system. So SBC efforts that do not take a systems lens may not yield sustainable and/or impactful results. And lastly, for the system to change, the enabling environment must also improve so that this is something that needs to be considered as we explore integrating SBC approaches into financial protection programs from a health systems perspective. Next slide. Okay, so what does it entail to integrate behavioral insights into financial protection programs? So social and behavior change is made up of many different approaches and methodologies. For the purposes of the brief, we focused on 4 common approaches and provided applicable examples for financial protection programs. So first, let's start with behavioral science, which includes insights on human behavior to design programs that support key behaviors. So some design examples include creating heuristics or mental shortcuts to lessen the impact biases have on decision-making, environmental shaping to narrow the gap between intention and action, and reducing friction to make it easy and convenient to participate in the program. The second example is community engagement, which aims to strengthen the link between people and systems by increasing the participation, collaboration, and voice of communities for better programming and results. So this can include institutionalizing community participation at each program phase from start to finish, conducting routine communication, and developing programming that is flexible and responsive to community needs. So our third example is social behavior change communication, which is a strategic use of communication strategies via marketing and public information campaigns to reach and engage communities, raise awareness, promote program uptake, and influence positive behavior changes. So initiatives may include two-way communication and tailored messaging through communications designed for a specific audience via their preferred news source. And our last example is a socio-ecological model, which is a useful framework for analyzing social programs, particularly with the systems approach. It looks at all levels of society that influence behavior including the individual, interpersonal, so that includes familial, peers, and households, then the community and services institutions, and then lastly with the policy and environmental levels. The model suggests that programs should target their engagement by level, iteratively and deliberately, to drive change by considering the complex dynamics between and within each level. So these 4 SBC approaches, theories, and models are all illustrative examples, as there are more options to choose from within the behavioral literature and programming. The selection and mix of SBC components that one may use to enhance financial protection programs will depend on which are best suited to the unique environment and behavioral barriers to implementation. Our forthcoming panelists, Matt and Jana, will discuss in more detail how they explicitly apply SBC approaches into their work. So you'll see how this works in practice later in today's discussion. Next slide. So as I noted, the brief includes some case studies, specifically 4. And so this summary here largely addresses 3 of the 4. I'll present on the 4th in the following slide. So first, we found limited examples where behavioral insights were explicitly incorporated into programming, implementation, and/or assessment. There are examples where it was implicitly used, but we found few examples that stated intentionally using an SBC approach. So even though we posit that financial protection programs could be improved using SBC, it seems that this approach is underutilized. And this is something that I also noticed while I was reviewing the literature at large. Second, friction and obstacles from cognitive, physical, and procedural barriers seem to impair program engagement and the program's intended outcomes, like removing financial risk. So just to clarify, engagement can entail users and communities, as well as implementers from health facilities, institutions, and up to the policy level. So this illustrates distinctive behavioral barriers for financial protection programs that could benefit from integrating behavioral science approaches to either improve or better tailor the program's design to a specific context and population, or even assess why a program is not working from a behavioral perspective to inform improvements. Third, some notable challenges of financial protection programs included issues with transparency and communication barriers due to infrequent or inconsistent communication and messaging, cultural barriers, administrative issues, and limited community involvement in the design, implementation, monitoring, and assessment. So in these instances, applying community engagement approaches or social behavior change communication might be useful behavioral approaches to improve programming. And then lastly, these highlighted behavioral issues were noted across all levels of the implementation ecosystems, from the community to the policy level, which illustrates that integrating SBC with the system's perspective, so moving beyond just the individual, so for example, the patient and provider, would be useful to improve existing or new programs, or to even understand why current programs are not achieving their intended outcomes. So as previously noted, an approach like this socio-ecological model is well suited to support an intentional systems approach to improve financial protection programs. Next slide. So here are some features that address behavioral considerations from our 4th case study, which was a social health insurance scheme in India. First off, this program succeeded in increasing health service utilization and reducing the financial burden of tertiary care for its focal population of households living below the poverty line. The scheme covered free care at the point of service, requiring no premium or copayments for select tertiary services, and was uniquely designed in a way that supported the eligible population to make use of its benefits. And employed a behaviorally aware design and implementation, which included 4 key components. The first is automatic enrollment through a related social service card that removed obstacles to entry, shaping the context and reducing friction for enrollment. Next, there was community outreach and engagement through organized health camps in rural areas for health screenings with referrals and transportation to tertiary care as needed, which also served as convenient communication advocacy channels. It also engaged with the private sector by contracting with both public and private providers, which increased geographic access to health services and potentially higher quality care. And then lastly, due to the provision of free care for select services, treatment was cashless, thus removing financial risk and obstacles to entry. So we can see that the scheme integrated behavioral science principles, community engagement, and SBC communication strategies to increase program enrollment and use. So this behaviorally aware design and implementation is hypothesized to have contributed to its success, which increased service use and then ultimately decreased financial risk. Next slide. So now that we've explored some SBC approaches and methods, and we've seen some case studies, how would we put this into practice? So our first recommendation is to ease participation using behavioral science principles. So make participation easier, reduce friction and obstacles that impede engagement with financial protection programs. Design programs for ease and convenience, including a supportive environment. And automate enrollment and entitlement, separate payments from the service delivery as we saw in the social health insurance scheme in India. And our second recommendation is to institutionalize community engagement with iterative monitoring and problem solving. So make sure to center community perspectives to include their insights on the needs and social factors within their context and population. And this should be done using a structured approach, so not ad hoc, and in a way that aligns with existing community and local systems and institutions. And our last recommendation is to target behaviors across the implementation ecosystem. So again, financial protection is a key component of the health system. So taking a health systems lens may support more sustainable impacts. So to do this, you'll need to identify challenges and develop tailored approaches from the individual to the policy level. The socio-ecological model is a great resource to support this approach. So design your communication approaches so the language, content, and delivery channels are based on your intended audience and the outcomes you're seeking. Engagement with local leaders should look different than with policymakers or district health leadership. Next slide. And here are just some resources. The first is the Spotlight Brief that is the focus of today's presentation, followed by some resources that we've developed through our activity that focuses on social behavior change for health systems improvements. Thank you.
Great. Thank you so much, Molly, for that really informative summary of some of the work coming out of the Spotlight Brief that you prepared. Really interesting to see the ways in which behavioral insights could make a difference in improving how financial protection programs are rolled out, and also noteworthy that there's not a lot in the literature about successful examples of where this has been done, which is a call to action, I think, for the economists designing some of these programs. I'm going to turn next to Matt Barnard for the next presentation. Matt is a consulting director at ICF, where he directs the Center for Behavior Change in London. He has 20 years of experience as a social researcher, behavioral scientist, and evaluator. And he is going to share a specific behavioral model and how it has been applied in one example of a financial protection program in Ghana. Over to you, Matt. Thank you.
That's great. Thanks very much. Great to be here. If I could have the next slide, please. So thanks very much. So I'm going to talk about our thinking in London that we've done around how to integrate social and behavioural thinking into behaviour change programs. And to start, just to sort of focus in on the sort of methodological or process element in terms of this is sort of a fairly common structure within behaviour change, although we've got some particular elements to it. So you go through a stage of diagnosing your the issue you're trying to address, so looking at what the target behaviors are, understanding the population, identifying barriers and enablers, then go into the design phase. We can draw on a whole range of different kind of models, of which I'm going to talk a bit more in a second about our model that we've developed, but some of them that have already been mentioned, including those from psychology or user experience design and economics. Then you go into a test phase, and we would sort of ideally recommend an RCT, a randomized controlled trial, if possible, as the most kind of robust method of testing interventions, but also QEDs, but really trying to understand how well something works, and looking at the cost effectiveness. And then something that is sometimes not emphasized in other kind of other processes is trying to build in a refinement stage. So as we mentioned, I've been sort of doing this work for 20 years, and almost a large proportion of the things that I've evaluated and researched, the interventions haven't worked, and which really just show that behaviour is very difficult to change, particularly entrenched behaviour. So building in a ability to refine your intervention before to roll it out, and actually building in that time and resource to do that can be a real benefit. If something doesn't work, you may be able to refine it so it does work, but even if it does work, you'll often find things that can be improved. So having that refinement stage is really important. So I now want to kind of focus in on really those first two stages, the diagnose and design stage, and talk about an approach that we've been developing in the centre in London that tries to integrate a number of the different perspectives and theoretical models into a single framework that we think could be helpful in particularly designing holistic interventions. So if I could have the next slide, please. So this is what we call the integrated model of behavior. And the idea is it nests within it lots of sort of existing kind of models and frameworks that have been widely used, but tend to be used in isolation. So things like COM-B, the capabilities, opportunities, motivation model that comes out of health psychology, rational choice and constraint theory from economics, behavioral insights, behavioral psychology, and implementation science. And so it focuses on thinking about motivation and all the things that go into people's underlying motivation, then thinks about how they make choices between the different options they have, because we're time and resource limited, individual time and resource limited, and then think about actually how do you execute those decisions, and then the outcome being both the behavior that you're doing, but also the impact of the behavior, as most behavior for humans is goal directed. It's not the behavior itself, it's the impact of the behavior. So it tries to nest these different existing approaches, and then tries to extend them by thinking more about this execution and outcome stage, and then the feedback process. And in this way, it tries to address some of those weaknesses that in kind of existing models, particularly things like the intention behavior gap in psychological models, and the choice behavior gap in economic models, and things like behavioral psychology, which can be very powerful, but they can tend to focus on nudges even when you need a more substantial intervention. So I'm just going to talk through really more a theoretical example of how you might apply this to a health systems change process. If we can look at the next slide. So just taking an example of conditional cash transfers and loosely basing it on the example of one that is in Ghana. But I say this is not something I was involved in. I've just tried to apply this model to that context for illustration purposes. So the first thing want to talk about is, so I've used those different parts of the behavior change pathway, motivation, choice, execution, and feedback to categorize types of barriers that people might face, individuals might face to taking part in a conditional cash transfer program. So they range from kind of those motivational ones in terms of lack of trust in the program, choice ones around expensive fees, some execution ones, how you actually undertake to do the activity, including travel difficulties, and then things to do with the kind of nature of the service and the outcome and what happens around long wait times. So those are sort of 4 different barriers that you might, and that literature has found have been barriers to taking part in the program. And then what I've tried to illustrate here is that they can be patterned across individuals. So those are the 4 barriers within a population, but actually individuals have different sets of those barriers. So here I've got person A has 2 barriers: lack of trust in the program and travel difficulties. Person B has the lack of trust and expensive fees as their issue. Person C is only travel difficulties, and person D is expensive fees and long wait times. So this is the kind of thing that we'd hope to look at in the diagnose phase, to really identify what are the different types of barriers, but also how do they pattern across people within the population, and what are the different variations and groups of barriers. If I could have the next slide, please. So then this illustrates some of the potential solutions or interventions you might introduce in order to address some of those barriers. And this is the idea, which is what often happens, is that there are individual interventions introduced rather than a holistic one. So the first intervention there is the trust building campaign, and what I was trying to illustrate with the crosses and ticks above is that a trust building campaign would probably help person A, where they just have lack of trust, but person B, who has lack of trust and expensive fees, is probably not going to do enough to address their barriers and doesn't address the other barriers. Similarly, if you look then across some of the other interventions, all of them are individual and potentially help some people, but not all of them, not all the people in the population, because they only address some of the barriers. So palace entry here was an example of a local intervention where in order to go to the palace, you had to show that you had your enrollment card, and so it was adding an additional sort of benefit of the scheme and a cost of not taking part in the scheme. So the idea here really is that if you just focus on one intervention addressing one barrier, then you may or may not be successful for some individuals, but you're probably unlikely to be successful for lots of individuals where you have multiple barriers. And if we can move on to the next slide. So then this is trying to illustrate the bottom line there, where your holistic intervention tries to combine all of those interventions into a single sort of multi-dimensional intervention. So trust building, the palace entry one, local health screenings, improved delivery, efficiency of delivery. And by addressing all of the barriers, you're then hopefully trying to address all of the barriers in all of the people from A, B, C, and D, so that you can see there's a tick there, because theoretically you've addressed the barriers for all of those individual people, even though those individual people had different barriers. So that's the idea, is that really you use this model to identify these holistic, or this is the range of different barriers, how they pattern across people, and then you try and develop a holistic intervention that addresses all of those barriers along the behavioural pathway, rather than just focus on one barrier, because that's going to really reduce the ability to address and encourage change. And then just on the last slide, so just to kind of conclusions, recommendations, to re-emphasize that it's really important to map those full range of barriers across the population and for individuals, and not just trying to think about whether it's one single barrier, whether it's the main one, because it may be the main one, but it doesn't mean it's the only one, maybe necessary but not sufficient to deal with it. Secondly, to target multiple barriers, and that's more likely to address different sections of population and different individuals within populations. And then finally, just whenever I talk about behavior change, and I spend a lot of time thinking about it and talking about it, but to emphasize that it can throw the focus on individuals, and it can be just as important or crucial to think about context and the structure within which people are operating, and that you can lose that by thinking about behavior change, because it can focus around those individuals. So it's really important to remember that they remain in context, and sometimes it's the context rather than the individual behavior you need to change or to facilitate it. So that's how I'll finish there. Thanks very much indeed.
Great. Thanks very much to you, Matt, for that really insightful model. I think there's a lot there that's very applicable, and I appreciate seeing this type of an approach applied to a specific financing intervention. I think it's super practical and relevant for people designing these types of programs, to consider a holistic approach and make sure that multiple different entry points are being considered. So thank you very much. Hope we can come back with some questions later. And then we have one last presenter. I will turn now to Jana Smith. Jana is a managing director at Ideas 42, where she leads the health portfolio both globally and in the United States. She has 20 years of experience developing, implementing, and scaling innovative programs in the fields of public health and financial inclusion, with deep expertise in gender and behavioral science. Is going to share a case study on applying behavioral design principles to an upstream health systems challenge, allocating adequate financing for family planning programs. So another great concrete example for us to review. Thanks, Jana, over to you.
Thanks very much. Can go to the next slide. So Ideas 42 applies what's called the behavioral design approach, which has a lot of similarities to what Matt had shared. It's a 5-step process that integrates behavioral science with human-centered design principles. The first stage is really trying to better identify the behavioral problem that we're trying to tackle. the actor, the kind of decision and the kind of action that we seek to see. And certainly in the case of a system level challenge, this may constitute the identification of multiple problems because systems are complex and there's often a great deal of interconnectedness between actors and the behaviors that they may be engaged in. The second stage, similarly to Matt, is to diagnose what is causing the behavior, and probably more importantly, what in the context is shaping behavior, because when we seek to develop the solutions, we're seeking to shift the underlying context rather than the individual themselves. Third stage being engineering that behavioral solution. So through a co-design process with end users, with our partners, ideating a range of different options, building out rough versions of what they might look like, and then teasing and testing out the details until it's ready for implementation, addresses the behavioral barriers that were identified, and also importantly fits the partner's constraints and possibilities. We seek to analyze solutions whenever possible, ideally through experimental or quasi-experimental methods, and then pursue avenues for scale, whether that be through facilitated adaptation from one context to another, or working with partners who might have scale baked in and be able to scale up on their own. Can go to the next slide. So the case study that I'll be sharing is one focused on upstream actors within the health system. This is a body of work that is certainly more nascent, and that's probably clear from what Molly shared from the landscaping. And for us, this is something that's relatively new as well. But this is one example of this work that we've been doing. This specific one was conducted under the USAID Breakthrough Action Project, which is USAID's flagship SBC global project. And this was focused on trying to increase investment in social and behavior change specifically among family planning investments. And the actors that we were focused on were government officials and funders. So as you can imagine, this is a pretty broadly scoped challenge. There's a lot of detail that we needed to try to parse out. So in terms of the what, we've tried to understand, how could we look at what are resource allocations that are currently going to family planning and how that money is getting divvied up. It was challenging, if not impossible, to determine what portion of that money was going to SBC more specifically, to be able to establish kind of a baseline to understand what success might look like in terms of an increase in investment. So I think that's the kind of challenge that we've bumped into sometimes. In terms of the who, certainly we couldn't leave it at the level of government officials and funders. That's quite amorphous, but the intention of this work was also that it could be broadly applicable to a range of different settings. So we decided to hone in on, governments in countries which were USAID family planning priority countries, which is certainly a pretty wide and diverse swath, but at least slightly more narrow. And in terms of funders, we looked at a handful of major family planning funders and tried to delineate again what might be very different funder categories that we might want to look at separately, understanding that their context may be quite different. So we looked at government development agencies at a headquarters level, government development agencies at a country level, and private foundations as 3 categories of funders. So in this identify phase, there was a lot of work that really went into trying to understand the who and the what of this. And certainly beyond this broad definition that I just shared, we spent a lot of time trying to understand how funding decisions were made. This really wasn't clear from documentation that existed or even a lot of the conversations that we had. It seemed to be that there was a lot of variation. And when we try to think about the application of a behavioral lens to a challenge like this, it's really important to understand, at what moment are decisions made around resource allocations? Is it a plan every 3 years in which, there are line items for different kinds of investments within family planning? Is it an annual budget, or is it actually on an investment or project by project basis that decisions might be made in terms of whether to invest in social and behavior change or whether to invest in, supply chain management? In addition to the when, the different steps involved. So, how are decisions made in terms of what to invest in? Are there meetings that are held? Are there consultations that need to be done? On the basis of what are these decisions made? And also importantly, who is involved? Certainly to look at government officials and funders at that very broad level isn't particularly helpful when we're trying to understand what might be driving their behavior. So not only who participates in this process, but who ultimately is making the decision. So we spent a lot of time in that stage trying to get a little bit more specific and gain a little bit more understanding, and also understand the similarities and differences that might exist across these key actors, so that we could determine what might be applicable across many different settings and what might be very specific to a certain kind of actor or a certain country. But the insights weren't meant to be country by country per se. In the diagnose phase, we looked at a lot of publicly available data. We looked at LinkedIn profiles, for instance, of individuals that worked within these different institutions. We looked at speeches, we looked at strategy documents. We also conducted qualitative interviews to really get a better sense of what might ultimately influence how family planning resources are allocated. And we found, unsurprisingly, that these actors generally had a pretty narrow view of when an SBC approach might be relevant, primarily around demand creation or community mobilization. That's when SBC was deemed as something that could be considered, and other kinds of challenges within family planning strategy weren't necessarily deemed as relevant for SBC. We found, a general status quo bias and a reliance on and a preference for tried approaches that had previously gotten results, because certainly it feels more comfortable, more certain. It is easier to budget and plan for activities that have been budgeted for in the past. And even though the context may have shifted and these approaches might not be getting the same results that they had originally, there was a bit of inertia to shift into other kinds of investments. We found that generally financial allocation decisions were made on the basis of national strategies, both by governments as well as funders seeking to support those government strategies. And these national strategies were often organized by health system components. And again, if people generally have a pretty narrow view of when an SBC might be applicable to demand creation, if someone is looking at a strategy by health system components, it seems like the majority of the pieces in the strategy aren't necessarily challenges that could be addressed by SBC. And finally, Colin made mention of, data at the beginning. Attribution is quite difficult if no relevant social and behavioral data is collected, even at the level of a correlation. It's very difficult to be able to say that an investment in SBC led to certain results in family planning, which that feedback loop also makes it challenging to shift investment decisions. There were a couple of different broad solutions that were recommended coming out of this work, which this is ongoing work. If you might go back to the previous slide, please. Thank you. So the first, to try to make the benefits of increasing investment much more salient, and not in general terms, not saying SBC can, increase your family planning uptake and kind of broad benefits, but actually getting quite concrete about, what are the resources that might be required in countries that might be quite similar to other countries, so deemed peers. Where did those increase of resources come from? Did they allocate it from another line item? Did they receive more resources in aggregate? So getting quite specific in those case studies. Seeking ways to decrease hassles and uncertainties in budgeting and planning for SBC, again, just to make it a little bit easier to overcome the, leaning into the status quo of what you're accustomed to budgeting for. And finally, as a means to try to, expand people's mental model of where SBC may be relevant, trying to highlight the applicability of SBC to the different health system building blocks, which lines up with strategy, as well as other donor priorities where it might not be deemed a relevant approach. Next slide, please. So this is, just one case example. We have others. So some of these recommendations and learnings come from the broader body of work that we've done focused on upstream actors. But I think, as I insinuated in the previous slide, trying to distill a system level challenge into specific behaviors often takes a lot of time. If you're focused on a community level behavior, like uptake of family planning or deciding to deliver in a health facility, there's a lot more work that's already been done in those areas, and it might be a lot easier to understand, what the rates are and what the specific behavioral challenge might be. Collaborative framing is important with all stakeholders, but certainly if you're engaged in work with government officials or other stakeholders, ensuring that there's a win-win and that the work can be clearly framed in that way is really important for stakeholders to be candid. We found that, these are oftentimes public actors, and what they engage in, the processes that they pursue, there may be a lot more publicly available data than is the case with community level behavior. So considering a wider and less traditional set of data sources can really help on the diagnosis phase. And finally, given the ambiguity oftentimes in that initial phase, to try to quantify behavioral problem, have a baseline, and then be able to pursue testing to generate empirical evidence can be a real challenge too. And a lot of innovation, I think, could happen in that space. Thank you.
Great. Thank you so much, Jenna. I also appreciate very much the practical nature of how you unpack each element of a decision-making process, and the reminder to look more broadly to help people expand their understanding of what SBC, how it can intersect with components of this kind of decision-making process, and how it's not just outreach and communication campaigns, which is how people have narrowly placed it into a box a lot of the time. I think this on the screen here is just one last helpful resource related to what Jana was just sharing. So I'm going to now open things up for any questions, a little bit of Q&A time. So please, anyone from the audience, if you have a question you'd like to share, you're welcome to paste it into the Q&A box that you'll find at the bottom. I am not seeing any questions there yet. So while you are all considering what incisive questions you want to pose to our panelists, I might just start with a couple that we've brainstormed ourselves. And the first one, I'll turn to either Jana or Matt. Either of you is welcome. But where would you begin, given the models that you've shared? Where would you begin when considering how to integrate an SBC lens or SBC approaches into financial protection programs? Do you have any suggestions for what the starting point might be?
I'm happy to come in, and really, I think Jana illustrated what I was going to say really well, which is I think the key rule is you've got to start from the perspective of the people whose behaviour you're trying to change. And I think a lot of times in behaviour change, in a whole variety of different fields, people who are trying to do the behaviour change start from their own perspective. And think, what do I want to achieve and what do I think might help that, rather than starting from the perspective of the people whose behavior is going to change. And you've really got to understand and locate your intervention in that perspective, and that will also tell you the barriers and why you need to understand and use behavior change, social behavior change techniques, because you'll see that it's just, these things are complex. People have a whole range of different pressures and requirements, and unless you understand that, you're not going to get kind of cut through. So that's how I would think about starting off.
Yeah, I think for me, just being very practical, somebody running a project, I think there are so many different behaviors. There's so many different things that could be investigated in health financing. And I think being clear around, do you need a quick win? Do you need some quick insights on a challenge that seems a lot more movable in the short term? And if so, maybe just spending some rapid time trying to, speak with a couple of people, collect some data, and then try something that might move the needle? Or do you really have the time and the luxury to be able to tackle something that might be a lot more challenging to address when it comes to the solution space, but seems absolutely essential to move the needle? I think something like shifting financing is quite complex and not very straightforward, as opposed to potentially just trying to get, you could imagine just trying to get a government official to attend a presentation about a best practice in health financing might be a very small behavior that would be very easy to see quickly if there are results. So I think just trying to understand the timeline that you have, the resources that you have, whether or not you need a quick win or not, because so much of this work is nascent, requires experimentation. There isn't a ready library of interventions with good evidence. So I think I would, knowing that there are so many places that you can apply it, and just kind of understanding as a project where you need to move, or where as a government you want to move.
That's fantastic. Thank you both for great additional insights. One other question I wondered if Molly might want to take this one is, you know, based on the analysis and review that you did, what do you think are some of the specific behavioral insights that are really critical for financial protection programs in particular?
Sure, I'll take a first attempt at that, and then maybe Kama can also help out. So I think that one thing that I think about frequently is putting, and this is mirroring off of what Jenna and Matt already said, is thinking about the experience of participating in that program. And so I think really putting yourself in the shoes of a user, so someone that is trying to get health services that's covered underneath the program, or an implementer who is supposed to make sure that program works. And so I think thinking from those two perspectives, for me, I think is really, really crucial. And the thing that did come up quite frequently was just how it was difficult to use these programs. And I think it might also be difficult to implement them. And I think thinking about those challenges, so like, what is it like to use them? What is that experience like? I think that's really important, on top of, because this is a really sensitive topic, thinking about social and cultural norms. We're talking about healthcare. There's a lot of tricky things to unpack. So I think really understanding the user's experience and understanding all the different ways in which there are things in place that there are barriers that are unintentionally put in place for people to use the program. I think that's really, really key. So I think really thinking from, I think the behavioral science perspective for me, I think is quite important. Also really considering the context and the social and cultural lens too.
Thanks, Molly. Kama, anything you wanted to add to that?
No, I think Molly covered it very well. I mean, I just think I think my camera, there we go. I think we underestimate issues around complexity in using a benefit. And I hear that quite a bit when I'm in countries that people aren't using, for example, social insurance because it's difficult. They don't understand how to get re-enrolled. They have to re-enroll every year, but also trust in the health system. So they may have all access that we can possibly think of, but if they don't have that benefit. So again, coming from the user perspective is really essential in the design of both the financial protection system and also the access and use of the financial protection system.
Thank you. I see one late breaking question in the chat from Nathan, which he's directed towards Jana. If you could elaborate a bit on the point that SBC approaches are often excluded from certain components of national health strategies.
Sure, I'd be happy to. So in general, when we were looking at family planning strategies, and I think this would apply across topical areas, SBC was deemed as appropriate for, mobilizing community members to go to a health facility. But there were perhaps other parts of the strategy that talked about maybe introduction of a new contraceptive method. And there wasn't viewed that could be something that social and behavior change could assist with, or quality of care, potentially trying to, train health workers in the application of a new method, or potentially strengthen compliance with clinical protocol, which are also behavioral challenges and elements that can be addressed. There may have been an element in a family planning strategy around decreasing stockouts without understanding that there are people that are involved in inventory management and supply chain, that a behavioral lens could be applied to that kind of challenge as well. So, a range of different issues on governance and, health workers and medical and technology, and none of that was deemed as relevant for SBC. SBC was only deemed as relevant for getting people in the door of a health facility. And I think that's really where we saw that it was so limited in terms of its influence because really the people that are involved in all those other health system components weren't deemed as necessarily, you know, human actors that might also be able to engage in a behavioral approach.
Yeah. Thank you, Jenna, for those last comments, and definitely hear that sort of like framing bias that we're just used to putting SBC in a particular box. And there's so many opportunities for human engagement where these types of approaches could have a lot of power. Well, we are at the top of the hour, and really appreciate the time that you've spent with us listening to these presentations. Thanks everyone for joining. And thanks so much to all of the panelists today. I found this actually super insightful as one of those wonky health economist types myself. So I really have appreciated the learning that was shared today. And just so everyone knows, we'll be sharing a recording of today's webinar along with these slides and the links to the different resources by email. And I think this will also be shared on our website as well, the Accelerator's website. So thanks again, everyone, for your time. And I wish you a wonderful rest of your day. Thanks very much.
Thanks, everyone. Bye.
Thank you.